Hello and welcome to the Frontline to Finish Line podcast, your go-to sport and exercise medicine podcast series. I'm Claire Spear, a specialist MSK and aquatic physiotherapist.
And I'm Dr Ed Appleby, a sport and exercise medicine specialty trainee working across MSK services and elite sports team in the Northwest.
Together, across this series, we'll be speaking to a number of industry-leading experts, exploring some fascinating topics across the multidisciplinary world of sport and exercise medicine.
We're delighted to have you join us, and we hope you enjoy the listen. Hello and welcome to this week's episode of the Frontline to Finish Line podcast. Today we're very lucky to be joined by a colleague of mine, Jim Kerss, who's going to go through the faculty minimum standards documents that have recently been published and are available online on the faculty website. So just a brief introduction to Jim. So he's head of sports medicine at the UKSI and also works across the Northwest at places such as the Orth Team Centre as well. But I'll let Jim briefly introduce himself and bring him onto the podcast.
Yeah, thanks Ed. Thanks Claire for having me on to talk about the work we've been doing in the Team Care Committee. So yeah, as you say, head of sports medicine at the UK Sports Institute, consultant in sport and exercise medicine. My role with the faculty is as chair of the Team Care Committee as well, which is hopefully why you've got me on to talk about the qualifications and certification document we produced recently.
I think hopefully very well placed to talk about that. Thank you for joining us.
Brilliant. Thanks, Jim. So yeah, well, Jim, why don't we start about if you could tell us about the sort of three strands of the faculty and I guess from there, the Team Care strand and your position on the Team Care Committee and what that means.
Yeah, happy to do so. Yeah, as a lot of people know, but some people may not do, the faculty focus on three main areas. So one is musculoskeletal medicine, the other one exercise medicine, and the other one is team care. And sometimes there's some confusion over what exactly falls into that, but it's basically trying to provide some degree of support for healthcare professionals who are providing healthcare to athletes, and also set minimum standards and help guide position statements that, again, will, with the ultimate aim of supporting real high quality care for the athletes who are based in the United Kingdom. So looking back, John Houghton, who you had on the podcast recently, I think was chair of the Elite Sport Committee, which was a representative group of different national governing bodies across the United Kingdom, and they did some really fantastic work. But the faculty developed committees both in the exercise medicine stream and also within the musculoskeletal medicine stream. So must have been about 18 months ago now, decided to do the same thing with a committee focused on the team care stream. So that's where I got involved. Originally, I'd been a faculty council member and led on the development of the Team Care Diploma, which I can talk a little bit about as well, if that would be useful. And so yeah, I was fortunate enough to be appointed after a recruitment process to be the chair of the Team Care Committee. And then we went on to, again, go out for a recruitment for the committee itself. So we've got 13 members now. They are all doctors, although we did make it available to allied health professionals as well. And they represent a whole range, so they're not all consultants, which is really important. So we've got a really, really strong group there of doctors working at various different grades across the United Kingdom, so representing all four home nations, which is really important. And it's been going just over a year now, and we've done a load of really, really great work. It's been really productive and a fantastic group of people to work alongside.
I second that, Jim. It's been a great portfolio of work that's coming out of the Team Care Committee. Just while you are on that, you mentioned the Team Care Diploma. Would you just tell us a little bit about that and obviously applications that are coming up for that and when they're coming?
Yeah, so that's the third sitting of that now is coming up in March, so at the end of March, 26th of March, and the applications are still open, so up until the 15th of February. So if you're interested in doing the Team Care Diploma, listening to this, you want to find out more, there's information available on the faculty website, and we'd strongly recommend people sign up to that. It's a fantastic exam and getting better each year with continued development. So, and it's for, important thing to know is it's for everyone working within the MDT, within a team care setting, providing healthcare to athletes. So yeah, not just focused on doctors. And that was set up, like I say, third running now, so a few years ago, with the intent to mirror those ones that were already existing in exercise medicine and musculoskeletal medicine. And we aim to basically set the bar worldwide for a minimum standard qualification that would demonstrate the minimum standard of competency, both in skills and knowledge, that a healthcare professional should have to provide healthcare to athletes, basically. So that was the intent behind it. And we've had good uptake and good feedback. And as I said, within the Team Care Committee, we've got a small subgroup now, are really driving that on and continuing to develop it, led by Andy Smith, who's doing a fantastic job with that.
That's great. I think it's a really good addition to the offering that the faculty are giving. Again, it just helps raise the standards, doesn't it, across both the professions of the doctors, but also allied health professionals. So really fantastic. And another thing you've been working on with a group of colleagues has been the minimum standards, which have just been published on the faculty website. Can you tell us a little bit more about those minimum standards in team care and how you're involved, how you developed those?
Yeah, definitely. The three ones that we've recently published relate to a minimum standard document on immediate care, so pitchside care, and another one related to indemnity for healthcare professionals working within team care in the United Kingdom. And then the third one is related to minimum standards of qualifications and certification for doctors working in team care settings within the United Kingdom. And the previous two were focused on all healthcare professionals. The latter one is at the moment solely focused on doctors. When we first did the scoping for it, we thought about doing it for all healthcare professionals, but actually it basically became too messy to put on one document. And the allied health professionals minimum standards is a really big, really important piece of work that we wanted to dedicate sufficient time and energy towards. So we focused the initial one on doctors, and my colleague Moise Mogal, who's one of the members of the Team Care Committee, is currently leading on the scoping of doing the same thing with the minimum standard certification and qualification for allied health professionals. So I'll give a plug to Moise and also say that if there are allied health professionals listening who would be interested in being involved in the first draft or review of any of the drafts of that document, then please get in touch. And we're really keen to work more with other members of the MDT and not just have that being doctor led. That's really important to us. So yeah, they're the three things. So immediate care, indemnity, and qualifications and certification, which I'm happy to talk more about. And like I say, we worked on a small subgroup with the authors there who put that together. So again, very grateful for everyone there for their expertise with it.
No, brilliant. Thanks, Jim. And it is a great portfolio of work that's all available on the faculty website. And I would really recommend people reading that who are working in sport. Today, we'll focus mostly on the qualifications and certification minimum standards. That was something that you're very deeply involved with, and obviously you're in a great position to speak to us about. So you've already said that it's predominantly aimed at doctors, but who is this document for? Is it just doctors? Is it for providers? And sort of roughly what does this include?
Yeah. Yes, it's all. I mean, all stakeholders involved in provision of healthcare to athletes in the United Kingdom. So you could imagine the primary focus might be doctors, but it goes much wider than that. So all employers of doctors who are working in team care, other stakeholders may include indemnity companies, national governing bodies. So the remit of it is pretty is pretty wide, and the intent behind it really was we felt there was, and not, this has been the feeling I think across many different people for a number of years, is the significant need for this type of document, because there have never been any minimum standards set on qualifications and certification for doctors providing healthcare to athletes in the United Kingdom. So this is the first step towards doing that. And if I go back to the original intent, is to try and provide the best standard of healthcare to our athletes in the United Kingdom. And we see a way of doing that is by setting a minimum standard for making sure that a doctor that an athlete is seeing has got a degree of minimum certification and minimum qualifications to be able to do that in a competent manner. So that was the intent behind it. Like I say, ultimately addressed to providing best care for the athlete, and hopefully is helpful for a number of different stakeholders to help with the minimum standards there of care.
That's so I'm shocked that there hasn't been the standards there beforehand. It's quite surprising, really, isn't it? Given the number of medics working in all levels of sport. I think, all three of us have worked in sport at different levels, and I think we're all very, very aware of the perception of what you think it's going to be compared to the perception of what it's like when you're in that. And I think to have those standards to support people through their career is really useful. Would you be able to give us a bit of an outline of the guidance and how people can use it practically?
Yeah, happy to do so. As you said there, the other thing to mention, as you said, is actually supporting the doctors as well. Like the worst thing almost as a medic and a healthcare professional is you end up in a role that's above your your competency level, and you end up working outside of the scope of your practice, whether that's intentionally or unintentionally, and you find yourself in that scenario. It's not safe for the doctor. So that's aiming also to actually, as well as providing decent level of care to the athletes, it's aiming to try and protect our doctors, really, for making sure they don't get put into those situations. Sorry, you had me at a tangent. Just
That's okay. I think it's a good reflection, isn't it? It does make you think sometimes the situations, certainly earlier in career, that you maybe find yourself in. But yeah, it was really kind of how a little bit of an outline of the guidance and how it can be used. That'd be really helpful, I think.
Yeah, sorry.
People.
Quite a tangent there. So first thing to say, like I say, it's related to doctors. We've called it non-grassroots sport, which is a follow-on use of the terminology that was used by the concussion guidance that was produced by the government. So non-grassroots sport, and the important thing is it's a guideline. So this is not a set of rigid rules that has to be applied by has to be enacted by every single sport, and particularly around the non-grassroots setting, where when we discussed with and consulted with the sports, it was felt that sports should be able to set where that limit sits in each individual scenario sport. But broadly, that would basically apply to athletes who are semi-professional, professional, or they're part of a performance-related program competing national and international level. So that can include, you can imagine, Olympic, Paralympic, Commonwealth sports. So hopefully it provides a degree of cut-off, but with some flexibility. So that was the overall focus of the document. We thought about putting together just in a Word document, but actually we wanted a quick reference guide for all the stakeholders, and that's why we came up with this table format that spreads over a few pages. And across the top bar, we basically wanted to try and break down as best we could the different stages of our work that we could imagine a doctor would be doing. And across those stages, we would imagine that there would be an increasing level of care provided in terms of complexity and demand, and therefore an increasing qualification and experience requirements as you're progressing basically from left to right across the table. So the four areas we came up with, one was immediate care, pitchside care. The second one was some provision of healthcare within a clinic setting during a typical week, as well as immediate care, or without immediate care for that matter. And we set that up to 2 sessions per week for this guideline. The next stage was where you can imagine a doctor will be working employed by a national governing body, sporting organisation or club, and they're doing more than 2 sessions a week, as well as the immediate care. And that's where we felt they were starting to take on more of the primary deliverer of healthcare to an athlete in that scenario. And then the last one is a senior clinical leadership role, which would be something like a chief medical officer for a national governing body, basically. So as you say, you can go across them with increasing qualification and experience demands. And then as we were going through, we basically went through the stages of, so for those levels, what level of medical training should you be at as a minimum? And then the next one was sport and exercise medicine specific qualifications. And then we went through different areas and we referenced the two minimum standards publications we talked about. So the about on immediate care and indemnity, we put particular reference to those doctors who'll be working with children and young people, so under 18s, and then reference a bit about prior experience and mandatory training, and suggested some guidelines and professional codes that doctors should have awareness of and have read. So hopefully it provides, like I say, a quick reference table, so any stakeholder can have a look and see, as a doctor, do I meet the area that I'm intending to do for this job? For someone wanting to employ a doctor, they could look there and say, this is what we're intending to put out there. What's the type of qualification certification we should be asking for as a minimum standard? And the same thing, lastly, like I say, there is directed at indemnity companies. If indemnity companies are getting requests to say, can you cover me for this job? They'll be able to reference that doctor's qualifications and certification that they have, and basically just decide. It would help them as a guide to decide, is this appropriate to indemnify this doctor for this job? So yeah, hopefully it's useful. That's the main thing. It's meant to be a useful thing for people to actually utilize, rather than just be sat on a file on a website somewhere.
No, I absolutely agree. And I think this is something that absolutely had to happen because there's a lot of unregulated work within sport. And at the moment, we don't have any guidance to hold it to. And this really clearly provides that. So how will this sort of be disseminated? You mentioned that this really needs to reach not just doctors, but all stakeholders within sport, and also sort of highlighted to sporting employers as well.
Yeah, so we're starting that from this month. So obviously being on this podcast is hopefully a helpful thing. It's available on the website. I know James has been doing a great job of trying to disseminate it via social media and other channels like this. Then through working networks, so out through the doctors, any membership within the faculty, BASM as well. So as far and wide as possible from within the sport and exercise medicine community. And then trying to target specific employers and national governing bodies to make sure that they're aware of this. That's why we involved them as consultation during the actual development of this work, to make sure that it was developed with, instead of we developing and then show them it as an end product. That was really important to us, to do it alongside the sport. And then I think that's and keep encouraging and talking about it, I think, is the important thing. And hopefully this will end up being part of normal practice for people when they're thinking about jobs, both as an employee, as a doctor, as an indemnity company, as an employer, rather than, like, my big fear is that we do this and then it's not used or perceived to be useful. That was the exact opposite of what we wanted to get out of it. And of course it'll be iterated and changed, but we're hopeful to launch this now January 2026 and keep it out until January 2028, and then seek feedback. So if people have specific feedback, then we're really grateful for that, and it will all go into future redesign, rewording for the next iteration in January 2028 is when it's intended to review it again.
That's with one thought is, I suspect, as often happens when new standards, guidelines are brought out, that people will look at this and there will be doctors that read this and think, oh, crikey, I'm working at this level and I haven't quite got all of the things that I should be having there. Most people will then try and act on that to bring themselves up to standards. But are there any consequences for kind of acting outside of the guidance? How do you perceive that working as time moves on?
Yeah, it's a good point. For me, like say, it's a guideline. So the faculty, there's no accountability. Say, for example, if a doctor is in a role, there's no faculty accountability if the doctor is in a role, for example, that isn't in the right column, let's say at the moment. There's probably two aspects to it, I would say. So you can see at the far end of the column for the clinical leadership role, we've made a statement there saying if you're already working a clinical leadership role in sport prior to publication of this document, then this would be an acceptable thing. So for doctors actually providing clinical care within sports, there naturally has to be some degree of leeway and flexibility. So rather than a hard stop at the end of January, I think read, understand, discuss with your employer, with your indemnity company, and understand the ramifications of what the guideline is. And I think immediately there probably wouldn't be any action. I was saying to Ed earlier on, I see this, if indemnity companies pick it up, I see in the future when doctors turn over jobs and then new employments are made, I see that's when, if the indemnity companies have picked this up, is the knock-on consequences for doctors who perhaps don't meet certain criteria would see that, is because I can imagine a scenario where the indemnity company would then be able to refer to the guidelines and say, well, actually, you don't meet the criteria for that role based on the faculty guidelines, therefore we're not able to indemnify you for the role, and therefore you're not able to do it. So I think it'll be a phase thing, like a lot of these scenarios where people may still be practicing that don't quite meet the guidelines initially, but I do see hopefully over time that will change.
I think it's a really important point you mentioned about the indemnifiers, because this is essentially, the faculty is a standard setting organisation saying what they feel the minimum standards should be. So you'd hope that the indemnifiers would take note of that, not just from a sort of stopping people working point of view, but allowing other people to work as well. Personally, as a sports medicine registrar, it's been really difficult to get indemnity over the years, not being on the specialist register. And I think this clarifies the scope of work that, particular, people like myself can do, so that you can go to indemnifiers with this document and saying you're meeting the minimum standards. So like you said, it's not just, stopping people in their tracks. I think it's facilitating work for doctors and protecting them within the minimum standards if they meet them.
That's the thing. There's a degree of protection there, as I said before, for the doctor. You don't want to be getting into a role where you're outside of your clinical competency or scope of practice. So it's definitely true. And we didn't want to set the bar too high to basically make working in sport inaccessible to many doctors. Like, you don't want it to be everybody has to be on the specialist register. So that's why we thought you need some degree of a nod to doctors who are still within specialty training programs, or who are, specialist, associate specialists, or, specialty doctors who aren't on training programs. But there has to be a guideline for that scenario, so that doctors on training programs aren't doing that without the knowledge of the training program director, for example. And again, that's why we put it in specifically, is that if you are on a training program, you must have written approval from your training program director if you're going to be working within, team care, a sports setting.
Absolutely. And I think especially for potentially people who are educational supervisors or TPDs outside of sports medicine, having this down in writing will give them that understanding to be able to regulate their own trainees and what they're doing as well. So I think it's really, really useful from that point of view.
Hopefully.
Supposed to pull it back full circle. Obviously people can go and read the guidance and see exactly where everything sits, but from the Team Care Diploma, how does that fit into this guidance and support people with that pathway?
Yeah, so that's within the sport and exercise medicine qualifications column. We've split that into essential and desirable criteria. So you, for the, as I said, left to right, for the provision of immediate care, we've put that as a desirable criteria, basically postgraduate diploma or higher postgraduate qualification in SCM or the diploma of team care. So it basically starts off there. And then you can imagine the next knock on box over is it becomes an essential criteria once you're basically doing any degree of clinical care during the week. So any of those roles where you've got less than up to 2 sessions of clinical care during the week, we'll put that really as an essential criteria that you should have a sport and exercise medicine qualification at postgraduate diploma or above, which would include diploma of Team Care, diploma MSK as well. So yeah, we've tried to do that so you can imagine moving across the different levels of work. You obviously have, what we think anyway, it should be obvious, is that you should have increasing sport and exercise medicine qualifications to justify that increase in clinical demand, basically, in the provision of care.
Just to sort of dig down into a couple more of the more specifics in the document, a couple of things that sort of jumped out to me from within it are, well, two things. So the first one, that you have to be above the level of F2 to work in the immediate care setting. And then the second one being to be a contracted team physician, doing more than 2 sessions a week, that you need to be on the specialist register. So it's just really interesting, and I think it's really good that this has been put down in writing. But I'm just interested to hear a bit of the sort of like the rationale maybe behind a couple of those specifics, and I guess any advice if people are working outside of those particular parameters and what they might do as a result of this guidance.
Yeah, so both of those came down really to what we felt was appropriate for the scope of practice and the level of training that those doctors were at. So we felt that any provision of athlete healthcare shouldn't be done before the end of the F2 level, and that was primarily because the doctors are still in the early stages of their training and should be focused more on as it's spelled out, the foundation, competencies and skills and knowledge for being a doctor as a whole, rather than doing that in athlete healthcare. So yeah, it was more just about appropriateness of level of the medical training, basically. And it's actually the same scenario for the cutoff, as you said, for once you go beyond 2 sessions per week of clinical care, you're going into the realms there of primary provider of healthcare for athletes. And again, we just felt it was inappropriate for doctors who are still on a training program, even if it's a higher medical or surgical training program, to be doing that. And we felt setting a minimum standard where those doctors were either on the sport and exercise medicine specialist register, GP register, or in fact any other medical or surgical specialist register in the UK, was an appropriate bar for that level of role. And if we go back to the original reason, was ensuring consistency and quality of provision of medical care to athletes. That's what this is all driven by. So that's why we wanted to set that as a clear minimum standard. In terms, you asked the other question about what should doctors do if they're in that, and they're, if they basically see themselves in a role like that, but they're still on a specialty training program. I think it would be, having to discuss that with the training program director, referencing the guidelines, discussing it with their indemnity company, discussing it with their employer as well, and then they'll be able to make an informed decision between all the different stakeholders within their own role as to whether that should continue or not.
Yeah, I think like it's going to be a gradual evolution towards this guidance, isn't it? And it's not necessarily, like we said before, it's just stopping people in their tracks and putting people out of a job. It's more a gradual evolution for employers to move towards this guidance.
Yeah, exactly. But definitely needs to be considered rather than ignored, and the conversation had again rather than ignored. And again, yeah, it's a guideline. It's not a rule.
I think again, it's really useful. We keep saying this, but I'm kind of taking myself back to the discussion we had with Dr. Jakes about the best practice guidelines back on the podcast last March, I think it was. And it, just having this discussion brings that document to life a little bit. I think people can often read these things and kind of maybe panic a bit, maybe just go, oh yeah, I think I'm fine. And that's that. And I think, it's making sure that these documents are live, they're used, they're useful for the people they're intended for. And I think you've really brought that to life with this conversation, James. So thank you for that.
Thanks, Claire. Thank you.
Yeah,
and a huge thank you to the team that worked on it as well, I guess.
Yeah, absolutely.
There's been a lot of input.
Yeah, they've done a great job. The Team Care Committee overall has been fantastic, and particularly the group that worked on these 3 documents. I owe a huge debt of gratitude because they put in a huge amount of effort, and also the Elite Sport Committee. Like I said, we were really keen to engage with the sports throughout this whole process. So the Elite Sport Committee still exists as a reference group that you can go to for first and second draft consultations for these type of documents. So they're really fantastic and giving up their time. So appreciate that.
Thanks so much, Jim. Like Claire said, I think you've sort of brought this to life, and I really do hope people go and have a read this. I hope that we can disseminate it far and wide to doctors and all stakeholders in sport, and that people start to make that evolution towards this guidance, because I think it makes complete sense. There's good rationale behind it, and it's important to have that guidance in there. So thanks so much again, Jim, for coming on. Claire, any final questions?
No, I think I'm quite excited to see the evolution of the AHP one, obviously from a personal perspective. A call out to fellow AHPs that want to get involved any level at the faculty, but certainly for that project, don't underestimate the richness of discussion and development you can have from being involved in those conversations. I think, please do get in touch.
I'd second that. We definitely need involvement for that. Like I say, thanks to Moise for leading on that project, but we definitely need AHPs to be involved in that. It's definitely not going to be just a solely doctor-led thing. The faculty is an MDT and organisation, and hopefully moving towards an MDT college. So, definitely important to get AHPs involved in the process.